This week on the BackTable podcast.
It's the complex problem solving that is the art or the craft of quality improvement. And we're already so good at that. So if you're someone who sees some things that are frustrating, maybe learn a couple of the tools, reach out to me. I don't mind. I'm happy to help you. And then see if you get that same sort of engagement by using that problem solving ability to have fairly quick outcomes. And I think thinking about quality improvement from that aspect has been very motivating for me.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Andrew Harris from the University of Kentucky, Department of Urology. Welcome to the show, Andrew. How are you doing today?
Hey, I'm doing well today. I appreciate the opportunity to be with you today.
Well, it's a no-brainer. I had the good fortune of getting paired up in Team Gonzalez with Andrew as a part of the AUA leadership course, and it was immediately exceedingly obvious to me that Andrew's got deep passion and expertise in quality improvement, patient safety, and really was a champion for our project. Well, I'll be honest, a lot of times when I hear about quality improvement or historically had heard about quality improvement, it was kind of like eyes glazed, institutional quagmire, hard to get super excited. And maybe I'll just ask you, what kind of got you interested in quality improvement?
I appreciate your question. And I also agree a lot of times it's easy to get lost in the big aspects of quality improvement that are high-level, systems-level initiatives, and sometimes we just don't feel we're really part of that, or how can we influence it? We feel like we're a cog in the wheel, and that's difficult. The way that I got into it was a very personal experience. It was back in 2012, and I had no interest in quality improvement and patient safety whatsoever. I just wanted to be a urologist taking care of patients, and was in the operating room, had a patient asleep, was going to perform ureteroscopy with laser lithotripsy, had the scope up, asked for a laser fiber, no laser fiber. All right, let's go check the supply room, no laser fiber. So I had a poor patient asleep on the table, ready to perform our surgery. They had to go to a neighboring hospital to get the laser fiber. So the patient was asleep while we waited on it. And then, we were able to get it completed. And my father actually runs a lean consulting business. And so very much from a surgeon mindset, I walked out, somebody should be fired, whose job was this, somebody screwed up. And he started asking me a lot of questions. Well, what processes do you have to make sure you have what you need? And I really never thought about looking at some of the daily processes in which we function from that perspective. And it just was very eye-opening to me. And I was like, you know what? I'm an analytical thinker. Like, that's how we think in the clinic. When somebody comes, we follow algorithms. And when we follow algorithms, patients have good outcomes, right? And I started to think that way and use that thought process on how we function every day outside of just patient care. Well, why isn't it algorithmic? Well, it can be. And so if we follow the algorithm, we have the stuff. Or if we follow the algorithm, the patient gets the right antibiotics. And that was just such an eye-opening moment for me that I just fell in love with it. And then afterwards, I was a young, motivated urologist in a small health system and was somewhat voluntold I was going to be the patient safety person. And I wanted to do a good job and just started to learn more and more about it. And then really just kind of fell in love with it from there.
Yeah, I love that. My first foray into kind of QI stuff formally, as I would have seen, it was some years ago, and we had a string of post biopsy infectious complications before we were doing much transperineal, and we really did a revamp of our whole protocol, rectal swabs, targeted plus augmented antibiotics, iodine preps, kind of the whole 9 yards. And saw like a dramatic decrease in our infectious complications. And it was kind of amazing to do something and see some output in a relatively manageable time frame. So I can totally get it. And that was the first one I was like, oh yeah, you can like impact change like in a bigger way than, one patient at a time, which was appealing. The other thing that I think is kind of cool is how you also use quality as a means of preventing burnout. And maybe we can do this in a two-parter. When you think about quality improvement, Andrew, what does that actually mean to you? And maybe talk a little bit about how you've personally benefited from some of the QI work that you've done.
Yeah, I appreciate those thoughts. And I love to hear other providers experience the eye-opening moment where we do something and everybody's just better. Your post-biopsy infectious complications were better. And I think for surgeons, we like immediate gratification. That's why we do what we do. And I heard this on one of your recent podcasts. You go into the operating room, you spend 3 or 4 hours, and you have immediate change. And surgeons, we love that aspect of what we do. And quality improvement, when you do it well, you see outcomes that directly affect your everyday life. And I think that's very helpful. So when I think about how I define quality improvement or lean methodology, to me, it's how do we grease the wheels of success in whatever process we're looking at to allow people to function at the highest level of their ability. So a lot of people, when they hear quality or they hear lean, they think that you're going to come in and cut people. We don't need half the staff that we need. I mean, if you go into a urologist's office and you tell them they don't need half the staff, you're going to get thrown out, right? Because most of us feel that we are currently functioning in a FTE strained environment, and you don't want to come in and say, well, that's what lean's about, because it's not about. What lean or what quality improvement is to me is making the processes easy so people have the time to do the things that they do successfully and can do well at the highest level of their ability to function. And that doesn't matter if it's the front desk person, doesn't matter if it's a medical assistant, it doesn't matter if it's you, it doesn't matter if it's an OR technician. Allowing those people not to deal with the red tape or other things that can be frustrating in your daily practice. And we all experience those. And very selfishly, those were several of the first projects I was involved in. And my brother also works in my father's business. And one of the first projects that we did was work in our outpatient clinic back in 2013. And the clinic was very frustrating to me, and I didn't know why. I did know that I was a solo practice. So when I say I was just the only urologist there. When I was not working, if I had time to go check my email during a clinic day or surf the internet, something's wrong. Like I'm an expensive piece of the puzzle in the clinic. And that really got me thinking. So I reached out to my brother, who is the lean person. I said, this doesn't make sense. Like, this is very frustrating to me. I don't get a lunch break, right? And my staff doesn't, or the staff of which we're working, they don't get a lunch break. We're always an hour behind. We don't ever get to leave the clinic on time. I'm late to my kids' games. And this is really frustrating. He said, well, let's take a look at it. Instead of, well, you should just hire more people. Well, lean people don't think that way. Like, you know what? Let's take a look at the problem and see if we can figure it out. And we had a scheduling problem. And so what was really hurting us is when new patients would come in, a lot of the female patients need a pelvic exam. Well, that takes a little bit of extra time in the visit. And so when we had female new patient, I was going to have some wait time in there while I was seeing one and waiting for the other ones to get set up. And that was obvious when we took a look at it. So when we changed the way that we schedule, we went we went follow-up, new patient, follow-up, new patient. And if there were two news back together, it was never two females back together. And that made a dramatic difference. We shaved somewhere around an hour and a half off of the day. The staff started getting a lunch break. They were very happy about that. The day became much more predictable. They got to take their breaks. And when you talk about fighting burnout, these are the kinds of projects that are dramatically impactful for everyone around you, right? Everyone in the clinic. It was easier for the front desk. They weren't getting angry patients yelling at them. Why aren't we back yet? It was better for the staff in the office because their days were predictable. And it was great for me because I was really, really busy during the day. I got to take a break in the middle, and I got to predictably finish when I thought I was going to finish. And so when you talk about fighting burnout, those kind of projects directly relate to everyone around you. And very selfishly, that's how I got into it. Then after that, continued to grow just a love for the science behind it. We're science-minded people, and that's why it just fits so well with what we do. And so I ended up, coming back after 5 years in private practice, doing a fellowship, got a graduate certificate in improving healthcare value with an emphasis in quality improvement, patient safety, and currently parlaying that into a master's degree in business. I've taken semester-long lean courses, Toyota lean courses, and after I saw how that can affect everyone around what we do, and myself included, I just continued to fall in love with it.
Yeah, that's really cool. In addition to, you've touched on patient safety, like for instance, the patient that was under for a ureteroscopy without a laser. You've touched up a little bit about burnout prevention. Literally it's time for you and for your staff. I have to imagine that that's beneficial. And it sounds like, if I'm hearing correct, that this has opened up some new opportunities for scholarship, for leadership, for you to continue to grow and develop as a person. Is that true?
Yes. Spending a lot of time trying to get better and trying to become a student of improvement has really allowed me to progress a career pathway I do not believe I otherwise would have had if I hadn't taken the opportunity to do so. And so now, 1 day a week, I spend just doing quality at the university. And those are some really, really big projects we're working on. And from a quality perspective, and I think to your point when we first started about people just feel like they're thrown in to the mix and they glaze over with quality, I think we miss the opportunity to get a lot of very smart people involved by not starting with small projects. Scoping a project is unbelievably important. And that causes burnout. When somebody says, you know what, Harris, I want you to go to the clinic and fix the clinic. I'm not going to give you any support. Just bring me back the results. I don't want to really go talk to anybody about, we want to make the clinic better. Just, you're a more junior professor, just go fix it. Then you run into barriers. Like, that is a great way for someone never to look at quality again and just think that the whole thing is a bunch of stuff that doesn't matter. I had the opportunity to go the other way, to see it matter very quickly, to make my life better, the patient's life better, the staff's lives better. And that's continued to grow as I continue to learn more and more about the science. And so I think how you get exposed is very important. That career lane is so special, in my opinion, because surgeons are uniquely positioned to have a massive effect on big health systems. And the reason is we're among a select group of wonderfully intelligent humans that get to see the entire healthcare continuum. We see the outpatient, we see the emergency room, we see inpatient, we see the OR, we see pre and post-op. Think of what other healthcare professionals get to see that continuum of care. So when you start to understand and function in the system that we do, you start to understand it. And when you start to understand the quality improvement principles of how we can make things better, it just lines up in a dramatically synergistic way. And so that career lane is wide open for people who want to get involved in it. And for me, it's just been growing kind of steadily over the past decade, very incrementally, and is now taking up 1 day at the university and probably a day and a half over at the VA. So I end up probably spend half my week doing this kind of work. I just love it.
So let's maybe talk through like the nuts and bolts, the anatomy of a QI project. And maybe we could go with like, let's call it a small one and then like a big initiative. From inception, team building, are we going into needs assessment, goals, timelines, deliverables versus I did this yesterday, I'm going to do this tomorrow, and that's a quality improvement project. So maybe we could run through that whole process and how you approach it from, again, like something relatively minor, limited teams, et cetera, to something macro going through, let's just say, the proper channels.
Sure. So I think that's a wonderful comment, a wonderful way to think about quality improvement. I do it the same way every time. Doesn't matter how big or small the project is. And the first part for me is always choosing the process. And that most of the time will dictate your success or your failure. And what process are you going to choose because of how you scope it? And so I'll give you an example. of a smaller project. And this also wraps into creating the right culture. All right. So we have been working very hard in our operating room here at the VA hospital on creating a high reliability surgical culture, the see something, say something culture, which I know you all are very phenomenal at where you work. One of our staff members came to us and said, I don't feel safe during care transitions in the operating room. If Harris, you're doing a radical prostatectomy and I come in to give the normal radical prostatectomy scrub technician a break, I have no idea what I'm looking at. It's dark. I don't know where the instruments are. You start asking for stuff. I can't find it. It's anxiety provoking and it doesn't feel safe. I was like, well, I appreciate you for bringing that to our attention. And by the way, 3 or 4 years ago, this never would have happened. And so it's a really testament to the hard work that they've been doing by trying to make things better. Because not one time did anybody point to that person and say, well, you should just be smarter. You should just do a better job. You should just know what he's doing, which are very non-helpful comments when you're trying to take care of a patient. Nobody wins in that situation. And so we started looking at it, and this person was correct. Like, we were not talking about near the amount of material we probably should have been in that care transition. And so we came up with a list. We put it through our QI algorithm that we have here. And we said, first we need to study it. And so when we studied it, we were probably only talking about 20 to 30% of the stuff that we thought we should be talking about. Like, where are the specimens? Do you have any instruments hiding in the bedside drape? Right? What is this canister on the back table for? What's in this syringe? It's dark. I can't read the handwriting. What specimens might come out while I'm out of the room? And I'm sure you've heard of institutions where specimens make it to the wrong place, right? People get injected with the wrong stuff. Like, this stuff happens because we don't standardize our communication in the operating room. And we came up with an algorithm or an acronym. It's called SHRIPS. And it just stood for the stuff that they wanted it to stand for. I mean, they drove it all. We just helped them with QI. And then we audited it after we put it up. We put it on these 2-foot by 2-foot laminated visual aids in the operating room, so everybody could see it anywhere. And one of the parts of that, which is very interesting, is asking the surgeon if it's a good time to switch or letting the surgeon know somebody's new. Because I would ask you, are you always aware when you have a scrub technician that changes? You're in the robot console, you're focused, you're operating, and then you ask for something, you hear shuffling. Like, wait a minute, I don't normally hear shuffling. Have you ever had that happen to you?
Yeah, honestly, it appears sometimes the frequency of breaks is so haphazard and all over the place that I almost don't even call for the scrub tech by name, because it's like a 50-50 whether I'm going to get who I think I'm going to get. So absolutely, yes, and it is frustrating. Well, it can be frustrating depending on how the case is going, time of day, complexity, instruments, etc. required. But boy, wouldn't that be nice just to hear, hey, I'm about to pop out for a break. Does that sound like a good idea to you?
And there are times in partial nephrectomies where I've said no. Like, if we're getting ready to go on clamp,
sure,
that's probably not. That's it. And people will be like, well, Dr. Harris, or well, Andrew, that's kind of being selfish of you not to let the person go on the break. Team, this is not about me. It's not fair to the patient, and it's not fair to the scrub technician to put them in that kind of high-intensity situation if they don't feel comfortable, right? So we're not really respecting our people when we don't give them good standards to follow or put them in situations where they're not prepared to be successful. So we talked earlier about quality is about allowing people to function in the highest level of their ability. That also means giving them the tools to do so. And so once we implemented SHRIPS, our communication was much better. And we had surgeons coming up and saying, hey, yeah, this was great. Like, I understood what was going on, who was switching. And then the measured metrics were almost 100% across the board of what the team thought we should be talking about. Again, totally team-driven. And so that project was phenomenal. We actually applied for that for the VA Shark Tank Award, which is a national award, and it was one of 10 winners across the nation. And so super proud of the OR staff for bringing the idea up and then going through the process. And also back to our earlier conversation about immediate gratification, this took a couple of months. And our communication is much better. People feel more comfortable in the operating room. And so for me as a provider and as a surgeon, I mean, that is a wonderful process of which to be a part of because it helps everybody be successful. And you know who wins in the end is the patient. And the patient's our true north. And so if we can do things where the patient is winning, it just makes us feel great. And it makes it feel like we're doing something very worthwhile. I would tell you two things about quality improvement. Then we'll talk about the big project. One is an Einstein quote, and it is one of my favorite quotes. And Einstein said, if I had an hour to solve a problem, have you heard this one? I'd spend 55 minutes thinking about the problem and 5 minutes on the solution. Right. And that is so important. So think about our daily lives and what we do as physicians and all the meetings that we go to and how often someone says, this is the problem, this is the solution. There's no discussion of how we're going to measure it. There's no discussion of what success looks like. There's no discussion of how we're going to appropriately allocate resources. And then 6 months later, either nobody talks about it or nobody knows if it's successful. Like, what feels like it worked? What does that mean? Right?
I love that. And I'm sure thinking about it, the implementation of it, it's not just a solution. Well, I do want to hear. I mean, I think that to me that does qualify as a pretty big initiative. Improving communication and people's sense of safety, patient safety, comfort, and so forth. That does seem like a big deal. But I'm also curious to know what your quote unquote big project is also kind of like.
Sure. So the other kind of QI macro point, I think, for people to understand is every system is designed to perfectly achieve the results it achieves, right? Processes are non-emotional. So they are going to function the way that they're set up to function. And so if you're frustrated in what you're seeing, the process is probably broken, right? And so a lot of times we bang our heads against the walls and we're like, well, so-and-so didn't do this or so-and-so didn't do that, or this is such a headache. If you step back and look at the process, you will see what is going on. Because again, every process is designed to get the results it achieves. So that's my other favorite thought of quality improvement. And that's going to be pertinent as we go into the next project. Do you want to, it looks like you want to jump in.
I do. And it's something I kind of struggle with, and I'll give you an example. So I'm a believer to some extent, and it's the process and not the person. That does generally resonate, but there is also, in my opinion, some person characteristics, and maybe I'll share an example. So I was involved in a process improvement project about preference cards, and honestly, I think it was a bait and switch because I was sold on this to be about turnover times, which is near and dear to my heart, and it turned into a preference card, which I actually found to be incredibly interesting, where optimized preference cards lead to, so many positive downstream effects, where case schedulers and case pickers and people that put stuff back, environmental impact, efficiency, and actually turnover time improves. And we had, the whole gamut from SPD to surgeons to schedulers to scrubs, circulators, and it was fascinating to hear all elements of it. But I was shocked because sometimes it would be, let's just call it belligerent surgeons that were the issue. And sometimes it would be lazy staff that was the issue. So maybe talk a little bit about your experience, involvement, both with process and with people. Or do you think they're truly separate?
Yeah, so I will pose a question back to you. Okay, so in both of those situations, would you want those people to get better every day?
100%.
How do they know how they did yesterday?
Yeah, absolutely. I think, measurement, metrics, sharing, relational, absolute, all of that becomes quite important.
So when you think about the belligerent surgeon, if that is true, or the lazy staff, which may be true, take time to look at what are the standards of which they are supposed to be performing and how are we auditing those. So if you go to the break room and there is a staff member in the break room who is not on break, that's a leadership fail. We should always highly consider having very clear guidelines of how we be successful on a daily basis and how do we measure. That's the only way have people are doing, one, what they're supposed to be doing, and two, how do you help them get better, and three, how do you give them the tools to be successful? When you say you're going to be at OR2 today, have a nice day, well, then what happens when OR2 is, maybe not functioning, they close early, maybe turnover time. Well, what's the impetus? How long should it be? What's the expectation? What's their job during turnover time? How do you know they're doing their job during turnover time? Who's auditing those things during turnover time? Who's giving the feedback to that employee of how successful they are? When's the last time you saw somebody come in with an audit sheet and watch one of those and then give the feedback to, hey, you did that in the precise order and exactly the way that you should have done it?
Not commonly.
Right. But however, if you go into some manufacturing plants where they have this down to a science, people know exactly what they're supposed to be doing for big chunks during the day. The operating room or the clinic will be hard to do minute by minute, but you get pretty close, right? So of when your breaks are going to be, how long you expect certain processes to take. If you do have downtime that's not break time, what can we be doing to help the system be successful? Checking the case cart for the next case. Go ahead and pull in the disposables that we know Dr. Bagrodia is going to need in his next case, instead of doing it when the patient's out of the room. Because once the patient goes out of the room, the turnover clock starts. So just things like that. So if we're not allowing people to understand on what metrics they're being measured, it makes it much easier to be like, well, they're just lazy, right? So that's a leadership issue. And the same thing for belligerent surgeons, right? So, what is the code of conduct and how are we evaluated? And how do you let me know how I'm doing? Because there are definitely times I'm in the operating room where we're more stern, right? Or one of my other, we'll diverge a little bit. One of my other favorite things about quality improvement is step number 2, which is communicate. And most of us are horrible communicators. And the reason this goes back to the quote-unquote belligerent surgeon, which is sometimes is very true, and those are HR issues. But how often have you asked a resident to do something and you think you're being uber clear, right? Dissect the endopelvic fascia. And then they start, and you're like, that is not at all what I asked you to do. And so with our residents, I'll pull them out and say, what did you hear me ask you to do? And it is not coordinated well. And so if you're talking about a defined point, a surgical step, and it's that difficult to communicate, imagine the communication interactions we have on a daily basis. Go turn over room 2. What does that mean? Right? That may mean something different to you than it does to me. And one of my favorite things to do, so I give this talk that I absolutely love called Fighting Frustration and Ways to Combat Burnout Through Quality Improvement. And I will always ask the audience if it's on Zoom to draw a pig. Got that from a University of Michigan lean talk. Or if we're in person, I'll give them a set of Legos and tell them to build. And no people ever draw it or build it the same. If you have 20 people in the room, they're all different. And I love that for 2 reasons. One, it just continues to fascinate me how special people are. And we all have different backgrounds. We come from different places. We've had different life experiences. And that means we understand things differently, right? If I asked you to draw a pig and I asked me to draw a pig, I don't know if we would draw it the same, right? We'd probably draw it different. And a lot of that's our life experiences. And so I love that. But then the other part of it, when everybody sees it different, you see light bulbs go off. And then you say, okay, let's draw this pig. And you show a picture, everybody gets a lot closer, right? Because then what I love about that concept is now we're all working off the same page, right? We've eliminated a lot of those communication barriers, and now we're all starting with the same footprint. When you can get to that, it allows us to streamline communication in a dramatically more effective manner. That's a very long-winded answer to your question.
It's not a long-winded answer. It's an awesome answer, and it's got me thinking on so many things. So we're trying to talk in some way about process, reproducibility, standardization to minimize variability, right? There's some push and pull between redundancy and dedicated teams. If we're going to stick to this example of, for instance, turnover times, efficient operating rooms, then we have culture, which you hear all the time, culture creation. You work largely in a VA. I'm in the University of California system where teams are heavily unionized and so forth. So now we've almost got these competing entities. I don't know if they're competing. Maybe that's not the perfect word. But on the one hand, we want to have standardization. We want to have processes. We want to have, you could say, close to minute-by-minute accountability. And on the other hand, we're trying to balance this, how can I help versus it's not my job dynamic. Perfect example, robotic case, as you and I know, once you kind of get docked and are cruising, a lot of it can be cruise control for the next several hours. During that time, I'm guessing that within a job description of a staff member, it could be that you're there to make sure you can troubleshoot, or you could prep the whole case, have things ready to go. So as soon as that robot's undocked, you're already 80% into the next case prep. So let me just pause there and get your feedback on how you think about some of these process-based things versus some of these other elements.
To me, they are quite intertwined. And the reason I brought up the specific example about shrimps earlier was because of the culture it took a couple of years to create. And that was brought to us by a staff member. And that was a phenomenal experience. When you try to do process improvement without culture, it becomes very difficult and it's very slow. And sometimes that's where you have to start. And when people start to see the benefits, start to see the wins, they start to come on a little more, just like the adoption curve. You've always seen that, right? You have the early adopters, the middle adopters, and late adopters. Same thing happens with culture and QI. The reason why the second step in the process for me, before we do anything, is always communicate with the key stakeholders. And that's always frontline, top line. And the reason is I'm trying to assess the level of buy-in from everyone to see if we're going to go to step 3. And if the culture is not right, we won't go to step 3. We're like, listen, we're not ready. Like people are not ready to tackle this project. We're going to do something else. And to me, that's why they're intertwined, because step 2 for me is always assessment of the culture if we're going to be successful. And so what I'll do now, and it took me a while to get to this point where I felt comfortable, is I'll talk to the leader, which is always well above me. Like if we've been asked to come in and help our team, like this is what the leader should strongly consider doing if this wants to be successful. And usually that's some sort of, please get in front of everybody and tell them this is important, because they don't care what I think. They care what the CEO thinks, right? If you're talking to the entire operating, or you're talking to the OR nursing staff, they don't care what I have to say, because I'm not one of them, right? But if it comes from the nurse leader or the chief nurse or the chief medical officer, their words drive impact. And then how are we going to hold people accountable, or how are we going to provide feedback and delivery? I will give them the information, but then that information has to be communicated. And if it's not a priority for them, then it's not a priority, then the project's not a priority. It's not going to win, right, when you're talking on the high level. So then you also have to understand the front line and assess their willingness. And so if you want to tackle a project, they say, we don't see the impact here. This is not important to us. Really hard to ask them to change. And so if you can use data and find people that are on the early adoption curve, then you can help fight that culture a little bit. But I appreciate your point, because it's really difficult to do quality improvement or process improvement in a bad culture. And I specifically said something earlier about if you were asked to go into a clinic and make change, and your boss or leader said, just go do that and bring me the results, which we see all the time, you're going to fail. And so someone who is knowledgeable about quality improvement or process improvement will go back and say, I appreciate your confidence, but can you please be part of the process? Doesn't take much, but can you please be the figurehead, or can you please tell people we're going to give them this feedback and we're going to assess it and those things? Because if it comes from me, it just doesn't carry the weight.
Yeah, that's a very helpful. And, when I think about barriers to change, probably the biggest one is culture, kind of set in one's ways, not open to change. The other thing that occurred to me as you were talking was really at first pass, sometimes I think the process and going through it formally can be a little bit off-putting, as opposed to let's just try something. And it actually came up somewhere over the course of the AUA Advocacy Summit where somebody mentioned that we're generally fairly bright, efficient, motivated people. If there were easy solutions, we probably would have figured them out. And I think that's kind of true, that if it was just like, let me do this, and then that happens, most of us would have gotten ahead of that as it pertains to patient safety, efficiency, burnout, wellness, all of that. So you've obviously spent some time kind of formally educating yourself, process improvement, smart paradigms, lean methodology. Can you talk about doing it off the cuff? Maybe where it's okay to do it off the cuff versus when you really need the structure, let's say.
Yes. Do you mind if I back up and comment on one of the things that you just said as well?
Please, yeah.
Okay. So would you talk about the culture part? One of the things our team always does is when we go into one of these key stakeholder meetings, it's always, how can we help, right? Not you're doing something wrong. So it's so much in how we communicate. If I come in and into your operating room, or our team doesn't say, Dr. Bagrodia, you're doing this all wrong. You're going to say, I've been doing this for a lot of years. What are you talking about? Go away. If I come in and say, what do you feel are your barriers to being successful today, and how can we help? You're going to talk to me. You're going to look at this in a totally different light. And that helps so much in culture. We're working on an endo project, an advanced endo project, an IR project right now. And all of those had to start that way so that people realize we just want to help. We want to make their life easier. We want to get those things out of the way. When you approach it, the conversation that way, people want to be involved. And if you're going to ad hoc something, that's the best way to start, right? Let's figure out something that's hurting my day and probably hurting some other people's day, and figure out how we can go from there. And we'll talk a little bit about that more in a second. I would like to bring up what you said earlier about some of the advocacy stuff. If there was an easy solution, we would do it. I don't know how true that really is, because I think that sometimes we may not see those easy fixes or think that they're particularly applicable. I'll give you an example. Do you all do a debrief at the end of every case?
Yes.
Right. Does everybody 100% hold to the debrief?
I would say that we're pretty good about it in my ORs. I don't know how rigorously it's followed, and in total full disclosure, sometimes if, we did a prostatectomy, blood loss are NCCs, specimens are this, rock and roll, not the full kind of laminated, posted 8-part comprehensive debrief. So I'll give myself like a solid B+ as a debriefer.
That's phenomenal. So I appreciate your commitment to patient safety and doing the debrief, but a lot of surgeons do not. And I've been parts of those processes about how we make that better. And at the VA, I was very plus minus about it until something happened to me where we lost, not necessarily lost, but where there was some miscommunication about some of the aspects of the surgery. And it was a perfect setup, different staff, different room, trying to squeeze a case in, like all the perfect stuff that you would line up. And then we ended up figuring it out, and it was fine. It ended up not being a big deal. But I just was like, why does this really matter? Until it mattered, right?
Yeah.
And so then at the VA, we switched, and now it's a computer algorithm that they can't close the chart out if we don't do it. And so now they will grab your feet and be like, you are not leaving the room till we do it. But you know what? Our debriefs are almost 100%. So that is my point about, if it was easy, we would always do it. I'm not so sure, because most of the time we're fine. And there's this element of drift that occurs. And this is more into patient safety, but if nothing happens 100 times, you think you could probably slip a little bit. And then I also think there's some just unawareness. So I'll give you another example. It's just like what we were talking about earlier about scheduling your clinic. Well, most of us, if you said, do you want to schedule your clinic to be more efficient, are going to say, yeah, that sounds easy. I'll do that. When's the last time many people have looked at their scheduling templates to make sure it's going to make for a good day? Right. So I think there's just some easy things that we can popularize to help people more successful in their day. So that's a great one. You're talking about ad hoc. It's just things in the clinic where you feel frustrated, or ways in probably mostly the clinic. The operating room becomes much more difficult because there's more parties involved. So in the clinic, anything ad hoc would be if you're sitting and waiting as a provider, or things that make you mad in the clinic. Not necessarily at the federal level. So not prior auths, or any of that kind of stuff. But let's give you an example. Let's say outside institution medical records. And you start looking at it, you're like, man, in the last week, I think I've spent 2 or 3 hours waiting on medical records. Well, that's probably an easy one. That one just makes sense. Why don't we just start getting the medical records before they get there? Let's start looking at the schedule 2 weeks in advance, or when they book their appointment, you have to bring all your medical records, or let us know. We'll fax them and get them, and let's check them off on the sheet. That's very ad hoc, very easy. Not so sure you need in-depth process maps of all of that kind of stuff.
Yeah, as you were kind of talking, Andrew, it seems like I kind of saw some parallels within even like academics or traditional research. Like let's say you're like a second-year med student and you publish a case report and you've like tasted the fruit of publishing and it tasted good, and then you do like a retrospective review that's never going to change anything. It's a little bit, you learn something about the process. It's kind of a quick win. Let's fast forward until you have a practice changing randomized trial, which really changes the game. And I think it's okay to think about that in the QI world. a couple of quick wins that are easily implementable. Maybe you just say, let's try to move away from printing documents, and you saved 20 reams of paper and you help Mother Earth and you feel good about it, and then you do something at a systems level. So I like that. And I like that, keeping it somewhat accessible, but also respecting that for high quality stuff, probably you should be a little bit more familiar with the process, not like I wrote a case report, now I'm ready to write a randomized controlled trial without understanding, clinical design, methodology, and so on and so forth. We've talked a lot about QI, and certainly when I think about QI, I think it's generally process improvement, like you said, patient safety, value-based care, efficiency, physician elements as well. Have you ever involved patients and their families in some of the QI work that you've done, just to make sure that what we're doing is actually, like you said, beneficial to our true north, the patients?
I appreciate the question, and I do not believe we have directly involved any patients or their families in any of the projects we have done, and mainly because those projects either have a fairly defined role where it will help the patient, or the patient never sees the process. So I'll give you an example of both. Getting in the operating room on time, they see that a little bit, but if they don't see the whole systems thing. So if we're working on first case on time starts, the patients don't necessarily see that, but it helps the system function better for them. And then when we were discussing like the Shrips project, that directly affects their safety in the operating room. And then some of the clinic projects on which we have worked, now that you're saying this, I wish we would have measured patient satisfaction, because we moved the patients much more on time. We just got done doing one, and there's a chief resident in quality and safety that works at the VA, and I am lucky to have the opportunity to work with a wonderful group of people to direct this fellowship, and they spend a year just doing QI at the VA. And it's a PGY2 or 3 surgery resident. They're brilliant. And we just did a project seeing, could we get more patients seen within 15 minutes of their appointment? We were only about 35%. And then could we decrease their non-value added time, or time they're spent waiting? And it was about 70% of the visits. And as we've worked through the process, and this one very much went through the rigorous QI process, we've gotten down to 80 some odd percent of them, well over 80% being seen within 15 minutes. And that total inactive time, I think, down to 45% of their time, which has been a dramatic improvement. And the main reason we did it was because we would get so far behind in clinic, the patients would be in the room staring at us walking down the hallway, or staring at the general surgery team. And they were obviously very frustrated. We weren't coming in their room. And now that's all better. But, I have not gotten to a project yet that had significant either patient or provider stakeholder level engagement, such as how do we communicate with the patients and how we get them here. And I'm actually working on, I appreciate you saying that, because I have actually may use that. I'll give you credit for it if I do, to assess some of these things. We're working on a project now. How do we get people to the hospital? How do we get them to the right place? And that would be a wonderful, wonderful opportunity to get some more stakeholder engagement. I don't know where that question came from, but just being able to give it our recent experiences, the patient advocate and the patient stories we just heard at the Advocacy Summit were so powerful. There has to be a way to marry that into some of what we're doing. So I appreciate your comment.
Yeah, that's exactly where the question came from, is, now in clinical work, shortages, telehealth, all these things that we're kind of thinking about at a policy level. I felt the same way. And I mean, I guess it's, we obviously, as a profession, hospital systems, doctors do try to, of course, understand patient satisfaction and address those issues. If it's parking's a total pain and it takes 30 minutes. So I guess, QI in terms of patient satisfaction is similar but different. And I'd also have to think about it a little bit more, Andrew. This question kind of came off the cuff, though, but it does seem like patient input, advocacy, however you want to measure it in terms of quality improvement, there's certainly very little downside. I mean, if it's an on-time start, Like if you're cruising into the OR 10 minutes after your scheduled start time, have you like immediately lost some degree of confidence in the system? If 8 people came in and asked you if you've been on a blood thinner in the last 7 to 10 minutes, are you kind of like, there's got to be a process here where we can stop doing this. If your Malapati score got checked 55 times between 5:30 a.m. and 7:20, how does that make you feel? But I don't know, something to think about, maybe a novel way to approach it. I'm sure in some form or fashion it's been done. Well, hey, Andrew, so I think we've covered a lot of things from doing this grassroots. I love kind of frontline, top line, doing this kind of really adherent to methodology. And as we approach an hour, I'd love to kind of get some of your parting thoughts on QI, empowering people to engage in QI, and maybe lessons learned.
Yeah, I appreciate your comments. And again, I appreciate the opportunity to have this discussion with you today. As physicians, we would say that, I think, you can correct me if you don't agree, that we like complex problem solving, right? Patient comes to us with a disease process and we got to figure out what to do to get them better. And so by nature, I think that we are great analytical minds. I think we like to solve complex problems. And if you're someone who looks at quality improvement with the eyes glazed over, when you do it the right way, that's exactly what it is. It's how do we use our problem-solving skills that we already are so good at to approach some of these processes with just a couple. The tools are easy. It's the complex problem-solving that is the art or the craft of quality improvement. And we're already so good at that. So if you're someone who sees some things that are frustrating, maybe learn a couple of the tools, reach out to me. I don't mind. I'm happy to help you. And then see if you get that same sort of engagement by using that problem-solving ability to have fairly quick outcomes. And I think thinking about quality improvement from that aspect has been very motivating for me. And then the other probably take home is when we communicate, quality improvement is mostly communication. I think a lot of people don't necessarily discuss it this way. But when you want people to change their workflows, there has to be an element of appropriate, good communication for people to understand why and what to do. And as surgeons, sometimes that's difficult. And this is why. And this is a lesson that it took me probably 5 years to learn. In the operating room, when's the last time that you asked for a hemostat and they didn't give it to you?
Fortunately, it doesn't happen very commonly.
Right. So in the operating room, when we speak, there's some level of credibility because we're attending surgeons that people listen to what we ask them to do. If you take that same mindset into a QI meeting with various stakeholders, you will lose credibility before you have the opportunity to gain it. And the reason is you haven't done a wonderful job at getting people's opinions on the table. One of the things I really try to work on is to be a better team builder and be a better leader by working with groups to allow the best ideas to float to the top. And those are not always my ideas. If I go in and I try to slam my idea on the table, that's what I did in 2012, 13, and 14. And it was kind of a tough road in the beginning because people didn't want to listen. And so you can't use that same mindset. You got to put on a different hat and be like, how can we talk with people about getting the best ideas to the table and ask more questions than you do make statements? Those kind of things that we all know, but you have to consciously think about those things. And usually in quality improvement, the people with which you are speaker, with whom you are speaking, they know their job better than you do, or better than I do. So for me to make assumptions that I know how to do a nurse's job better than her, or him or her, or a front desk job better than them, I just look dumb. I look arrogant. I come across as a snobby surgeon. And then nobody wants to be on your team. So when you approach it of, how can we help you do better? Show me what you're doing and where we can help. And then use a little QI spin on it of how we get rid of waste. You'll be dramatically more successful. And, that level of communication, again, the QI stuff, not difficult. The communication is arguably more important than whatever methodology you're going to use to make the process better. And it's taken me a little while to learn it, and I'm still trying to get better at it every day.
Well, thank you, Andrew. Thank you for sharing your time and your expertise. And the only other things I'd maybe add on is don't be intimidated. Don't be shy. Get on in there. And I actually think there's a wonderful network of mentors with expertise in QI like yourself that are happy to help. It doesn't, these days, it doesn't even need to be institutional specific. So, Andrew, look forward to watching your career and both micro and macro mega changes come out of Lexington. And once again, thank you for coming on the show. Really appreciate it.
Yeah, thank you for the opportunity. I enjoyed the time, and continuing to get to know you has been a pleasure, and look forward to the future.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.